The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus, back with Josh Bonkowsky this week to field some questions that came up from our time together this week. Welcome back, Josh.
Thanks, Paul. Great to be here. Excited to talk to you.
Yeah, delightful neurologist, a great scientist, and author of the recently published book, Dancing Eyes, Dancing Feet, which I really enjoyed reading. Should we dive right into the questions?
Yeah, I think there's some great questions from the podcast that came up from people.
Josh, would you like to tell us about your disclosures?
Disclosures. So I do some consulting work with Ionis and Calico, and then we have some clinical trials going on with Calico and Ionis, but nothing related really directly to the content that we're talking about today.
All right. Let's dive right in with the first question. This is a multi-part question from the ever delightful Chris Campbell, former guest on the podcast, who starts out by saying, I loved your recent podcast episode with Josh. He's such an impressive clinician researcher and just a good person. There were a couple of points related to child abuse, which is her field of interest, that were really great and yet I feel could also benefit from clarification. Here's the first part of the question. Do we know, and how do we know, which children who are diagnosed with BRUE, B-R-U-E, should be evaluated for child abuse?
That's a great question. I almost feel like I'm in the position of bringing coals to Newcastle here with Chris Campbell asking these questions, who's an expert here at the Department of Pediatrics in child abuse.
Josh, it feels like that if this were a game show, that we would be able to do Phone a Friend right now.
Oh, 100%. We should ask her what we should do here.
Give us your perspective.
I think the big shift that's happened really, I guess, over about 10 to 15 years is that the field was stuck with this definition of ALTEs, or apparent life-threatening events, and that was a real mess, and shifted to a new definition of BRUE, which kind of cleaned up the categories of who should be, what infants, how to consider them, how to do the workup. And during that transition, it was clear that, one of the major concerns for a kid coming in with a BRUE was the potential for physical child abuse. And so what's happened since that time in the past 10 years has been, I guess I would say it's been rather unsatisfying as far as child abuse, in that the definition of BRUE has been cleaned up. People have done some large multi-center studies looking at serious outcomes for BRUEs, but none of those studies have looked in a kind of a consistent fashion at the risk for child abuse or followed infants longitudinally, meaning that they do the study, they evaluate in the hospital, but it's not clear, are they missing kids who either have had child abuse or go on to have child abuse in a defined time period. And so I think that's a great kind of opportunity for someone to own understanding better what the risk is for child abuse related to having had a BRUE.
And I think that you've partly answered and leads into the second part of the question. How does the social history help identify opportunities to prevent child abuse?
So this kind of harkens back to older data now, kind of at the ALTE to BRUE transition, where it was clear that it was like we couldn't see what it was, what was the signal, but there's something about the risk for child abuse being picked up upon by clinicians, like in the emergency department or upon admission, that led to kind of refer further workup for child abuse. It wasn't like physical exam findings or something. And so no one seems to know what that signal is. I mean, no one knows in a way to say like, oh, here's what you should be looking for. And so I think we as a field have kind of decided that as a quote unquote social history, but that's kind of a weak thing. Like, how do you tell an ED physician, oh, take a social history? Like, what does that mean? I mean, we're just taking people with certain background or certain socioeconomic status, that's not very helpful. So I think we feel like there is a risk there of some kind, but we don't know how to tell or quantify it. So again, that's something that could really be improved.
Josh, sounds like maybe we ought to have Chris back on the podcast and have her give us some elucidation about this.
Yeah, I feel like it's a problem waiting to be solved, and I think that
Right.
it would be a big favor for everybody if we could help get someone to tackle this problem. And so I think Chris could help lead the charge kind of nationally to do that.
And I think one thing that's clear to anyone who has practiced for any length of time is that I think the social history can be very surprising in terms of which kids are at risk. That anyone who's done this for a while will have seen at least some cases where they said, I never would have thought.
For sure. Or, we get these consults where the emergency department physicians saying, we're worried about this, we don't know why, but we're worried. They just have the people who've been in practice for a while have this second sense or sixth
Right.
sense, I don't know exactly which sense it is, that there's more to the story that needs to be followed up on.
Wait a minute. Is that something you learn in neurologic training? Which sense is which sense?
I was supposed to learn it, but
Question number two. And I think that as we approach these last three questions, each one probably could represent a semester course, but we'll just ask for the elevated vision about this one. Number two, as we learn about the genetic and neurologic basis of developmental disorders, what should the average pediatrician be doing differently today than we were 10 years ago?
that's a great question. And I think that probably really boils down to, in a much more succinct way, hopefully some of the message here is that the tools in testing, particularly the whole genome sequencing or brain MRI testing that can be done, can often give an answer now that it wasn't available 10 years ago for a child who has developmental delay or a child who has autism. And that answer matters, that the family kind of knows what they're dealing with, has a trajectory for the future. And so and I think that it's intimidating as a non-specialist to think about genetic testing or brain MRI, but that you can start the ball rolling and get them into the pathway with a neurologist or a medical geneticist, and that those answers matter. I think it's helpful for the family, it's helpful for the kid sometimes, specifically like for treatment choices. So that's the really big difference, I'd say.
And I think one of the things that we rely on, those of us who are practicing as generalists, is that it's nearly impossible to be on the forefront of this knowledge. And so I think that recognizing that collaboration is absolutely key here.
Yeah, I think it's harder now than it used to be because I think when the general pediatricians were rounding on their own patients in the hospital, there's much more kind of, you just would bump into people walking around the hospital. So it's kind of easy to buttonhole somebody and not feel like you're being inconvenienced, but trying to make friends with one or two people in the specialty field and just have them be your point of contact for making sure you're thinking through something rationally is really worthwhile.
Because in the current age, you got to curbside people virtually, as it turns out. So that's what we're doing today, Josh.
Yep, yep.
Next question. Both of these questions are going to be a little bit similar to the previous one. What do you wish pediatricians understood better about the relationship between a child's genes, brain development, and the symptoms we see in the office?
That's an interesting question. And I feel like I only understand part of the response because I think by the time someone is referred to me as a pediatric neurologist, the pediatrician's often done the hard work of trying to suss out what's really driving some set of issues. But the thing I often talk to families about is that if the child has a difference in how the brain is formed, like they have a change in their brain structure or they have a genetic condition predisposing them to behaviors along the autism spectrum disorder, that the way they interact with the world or the way they respond to correction or sitting in a class, a chair at school, is really different than how you or I or a kid without these issues would sit in school. And so the wiring of how they're dealing with the world or how they're dealing with interactions is totally different. And we have to think about how to adapt to that individual child. It's a different wiring system. And so we have to kind of modify our treatment plan and approach for that child differently.
Very interesting. Okay, next question. This question may be as long as the answer, so brace yourself, put your feet up. Your discussion of gene testing and therapy was both fascinating and exciting. Would you mind explaining the notion of precision medicine? It's a term that we hear more and more frequently, but I'm not sure I really understand what it means. what the implications are, and how soon it might become a major part of medical practice. In other words, how close are we to the point where understanding a child's specific genetic diagnosis actually changes treatment, not just the label we put on the condition?
That's an interesting way to kind of think about it. So precision medicine, the questionnaire is entirely correct. It is a kind of loosely thrown around term and kind of a catch-all. It is useful as a way to try and convey a meaning of where things are at now that there is this opportunity for genetic testing and genetic medicine. So it's not a precise term, but it is helpful to think about genetic testing for conditions like developmental delay or autism. So I think that's the key message about precision medicine, is that it's the idea that you can do a genetic test and find an answer for a condition where we think there might be a genetic component. I think the second part of the question was, does it actually matter? Just to kind of boil down to what they're asking. And I think more and more it does actually matter that there's enough community and other people in the world with the same genetic diagnosis so that for the family, they're not flying solo with this child with this condition. They can reach someone in Australia or Germany where they're like going through the same problems with tantrums or with needing a wheelchair and knowing what to expect in the future. And that makes a big difference, both for not feeling alone as well as for kind of having a little bit of expectation of what their life looks like with their kid. And then, although it's slow and annoying, there are treatments that are kind of popping up here and there for many of these conditions. And sometimes they help a little bit, sometimes they help a lot. And so it is making a difference in kind of surprising ways. Like we just a couple weeks ago, we had a family from Montana in the hospital, a little kid who's doing well, and all of a sudden had this very sudden onset of inability to walk or kind of went a little bit comatose. And we did this genetic testing in the hospital, and it came back with a condition that's treatable with vitamin B6. It's not a cure. They aren't going to be completely okay, but the vitamin B6, like a super easy treatment, is going to more or less get them back home and get them able to walk again. And so that's just a dramatic example of a pretty simple treatment for a complex genetic disease.
And Josh, again, as a generalist, as I've seen the expansion of the metabolic screen over time and seeing the profound difference it's made in some of my patients with early identification in those diseases, that there are some very simple interventions that make a lifetime of difference. And I'm guessing that from what you're saying, that the hope here is that the more precisely we understand what's going on at an earlier stage, the more we can intervene. Maybe vitamin B6, but as you talked about in your episodes, other things that show promise like genetic repair and that sort of thing.
Yeah, I think one of the interesting problems is that we are almost outstripping the newborn screening now. I met with the state lab a couple weeks ago because there's a couple more disorders that have treatments, and now we have to think about, can we get them on the newborn screen? Because if we don't screen them, then we miss a window of time for treatment. So both problems are kind of happening in parallel. So it's really interesting time to be alive.
Absolutely. When I started practicing, and admittedly that's been a few years ago, there were 3 items on the newborn screen. And now in Utah, there are over 40. And I have seen in my patients profound differences in the things that we've been able to do.
Yeah, that's super interesting. I wonder, not to suggest ideas to you, but it might be interesting to talk to someone from the state lab at some future podcast because they are at the front lines of which tests to add, how do you choose a test to add, what does it mean to actually implement it, what does it mean for cost, all these super logistical type questions that then turn into the reality of like what we see in the clinic or in the office with patients.
Well, spoiler alert, it's something we have been working on. We're just trying to find the right person to talk to. And maybe
Oh,
offline we could talk about who the right person would be. Well, Josh, thank you so much for taking time to talk with us this month. This has been very interesting. And I think that a lot of what you're doing, from my perspective, has really sort of opened my mind about thinking about not only what's happening now, but possibilities for the future. So thanks for being our guest.
I appreciate it, Paul, and I look forward maybe in a few more years to touching base again.
Let's do that. And, you may become someone's phone a friend too. So keep your phone with you at all times.
Very good.
All
Thanks,
right.
Paul.
Thanks, Josh. And to our listeners, thanks for listening. Stick with us. We'll have another topic next month. Thanks for listening. All right. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.